Hi everyone, this video will see about diseases of blood. Hematology is a very important topic because it comes under different subjects like general path, general medicine, general surgery, oral path, oral surgery, oral medicine, and physiology, little bit of biochemistry and pharmacology as well. So because it is covered in all these subjects, you can expect some question or the other from hematology from all these different subjects. Question can be from the physiology part or from the pathology part or from the clinical part, applied part of it. So this video will focus mainly on the pathology and the pathophysiology of it. So the contents of this video is only related to the diseases. We have diseases of RBC, diseases of WBC and diseases of platelets. So first is diseases involving RBC. So under RBC there are various types of anemia which will be seen through. Only the salient features of each of the clinical condition will be explaining here. So first off, pernicious anemia. Pernicious anemia occurs because of vitamin B12 deficiency. It is also called as Weber disease or Addison-Weber disease. So pernicious anemia, when there is B12 deficiency, dietary B12 deficiency, there is loss of intrinsic factor, then it might lead to pernicious anemia. So, we will be explaining them what is an intrinsic factor, what is an extrinsic factor. So, intrinsic factor is present in the stomach, it is secreted by parietal cell, whereas the extrinsic factor is the dietary B12. So, these two has to get, these two will form a complex and the B12 gets absorbed in the ileum after this complex. So, now this Addison-Weber disease is a pernicious anemia when the B12 deficiency is associated with clinical findings like generalized weakness, sore painful tongue. The ulcers are called as Mueller's glossitis. There is numbness in the extremities. Then this condition is called as Addison-Weber disease. Now, what is the difference between a pernicious anemia and a megaloblastic anemia? Pernicious anemia will lead to a condition called as megaloblastic anemia. So, as we all know, RBC gets matured at different stages from the normoblast, finally it leads to the erythrocyte stage. So, when there is any defective maturation in the cell, it leads to this megaloblastic anemia. And one of the main reason for megaloblastic anemia is a pernicious anemia. So, now when there is impaired DNA synthesis, there is delayed cell division. Even though the hemoglobin synthesis is normal, because of this impaired problem, there is defective nuclear maturation. Because of that, it leads to a condition called as megaloblastic anemia and it presents as macrocytic anemia. So, macrocyte, as the name states, macro means bigger, cyte means cell. So, the cells are bigger, which means larger RBCs will be there in macrocytic anemia, which is caused because of megaloblastic anemia. So, now megaloblastic anemia occurs because of condition called as vitamin B12 deficiency, which is pernicious anemia. It can be because of B12 deficiency or it can be because of folic acid deficiency or both. Now, why is this B12 and folic acid required? B12 is required for conversion of homocysteine to methionine, whereas folic acid is required for the synthesis of thymidine triphosphate. Both together is required for the synthesis of DNA. So, when there is deficiency of B12 and folic acid, this deficiency will lead to a megaloblastic anemia. So, which means the reason for megaloblastic anemia can be B12 deficiency, which is pernicious anemia, or folic acid deficiency. These two together will lead to megaloblastic anemia. Now, what is the association between the intrinsic factor and the calcium? So, parietal cells in the gastric mucosa, we have various types of cell and various substances are secreted from different types of cell, of which the parietal cells secrete gastric acid and intrinsic factor. So, this intrinsic factor is also called as intrinsic factor of Castell, and this intrinsic factor combines with the extrinsic factor, which is nothing other than vitamin B12. These two combines and this process is a calcium dependent process. After the combination in the ileum, B12 gets absorbed into the blood. So, this B12 absorption is a calcium dependent process. Because of that reason, whenever see a patient with the pernicious anemia, we give nutritional supplement in the form of B12 injection, and also in the oral tablet we give vitamin supplement which also contains calcium. The reason for that is it is not only enough if you just supplement the patient with B12 thinking it is a B12 deficiency. There can be a folic acid deficiency, or if you have found out there is B12 deficiency, then there might be a condition where the patient is having a little bit of calcium deficiency. Because of that, the B12 absorption does not effectively take place because the reaction is a calcium dependent process, and that is a reason why we supplement them along with calcium as well. Some of the findings which you see histopathologically includes presence of Howell-Jolly bodies. So, Howell-Jolly bodies, they are small round bodies composed of DNA, and they are visible in right Gibbs stain. So, the reason for the presence of Howell-Jolly bodies in condition like megaloblastic anemia is, as I have already stated, RBC, the final stage of RBC, the erythrocyte contains no nucleus. So, before those stages, it has other various stages like normoblast, they will contain nucleus. Finally, when it reaches the final stages of RBC, the nucleus gets removed by spleen. So, when there is condition like megaloblastic anemia, because of defective nuclear maturation, the nuclear remnants will be there, it will not get removed. So, because of nuclear remnants in the histopathology, you can see presence of Howell-Jolly bodies. So, it is seen in condition like megaloblastic anemia, and also as I have already said, these nuclear remnants are removed by spleen. So, which means spleen is the one which is responsible for removing this. So, either there is some defect in the maturation itself, it will not get removed by the spleen. So, that is a problem in megaloblastic anemia, whereas in other conditions like a spleen problem. So, spleen problem can occur because of either there is anatomically absence of spleen, or functionally it is present but it is not working, which means functional asplenia, or it is being removed after a surgery. So, post splenectomy cases. So, because of those reasons, the spleen cannot remove the nuclear remnants in the RBC, and in those conditions also we will find Howell-Jolly bodies. Apart from that, it is also seen in condition like thalassemia. Next one is presence of Cabot ring. So, Cabot ring is a loop-like or figure of 8 cytoplasmic structures which are seen in RBC. So, in the precursors of RBCs only we find structures like Cabot ring and Howell-Jolly bodies. So, in a normal RBC if you see, you should not find structures like Howell-Jolly bodies and Cabot ring. If it is present, it means the RBCs has not matured, it is there in the premature stages. So, you have to think of megaloblastic anemia. Next one is aplastic anemia. So, aplastic anemia occurs because of lack of bone marrow activity. It presents as peripheral pancytopenia. So, pancytopenia means what? When there is cytopenia, which means decrease in cell, cytosis means increase in the cell. So, pancytopenia, pan means everything. So, pancytopenia means there is a decrease in the cell count in RBCs, WBCs and platelets. So, all the three cells are decreased in aplastic anemia. Types we have primary and secondary types. The primary aplastic anemia, the important one which comes under primary aplastic anemia is Fanconi syndrome. So, if you see primary mainly involves Fanconi's anemia or other gene mutations. It is a genetic defect, whereas secondary occurs because of any reasons which happens after birth. So, it could be any cytotoxic drugs or radiation, or it can be sometimes idiopathic or triggered by conditions like hepatitis or thymoma. So, this will lead to peripheral pancytopenia. Clinically, in the oral cavity, it presents as petechiae, purpuric spots or any frank hematoma. Next one is thalassemia. Thalassemia is a hemoglobin disorder. There is decreased production of either alpha or beta chain. So, now thalassemia, you can group them as alpha thalassemia or beta thalassemia. In alpha, there are 4 genes involved in alpha hemoglobin chain, whereas in beta, there are 2 genes involved in making the beta hemoglobin chain. So, under alpha thalassemia itself, we have alpha thalassemia major and alpha thalassemia minor. Under alpha thalassemia major, if there are 4 genes mutated, it usually results in death. It is a very rare condition, and it leads to a condition called as hemoglobin Barrett's disease, presents with hydrops fetalis. If 3 genes are mutated, again the patient will have moderate to severe manifestation. The condition is called as hemoglobin H disease. Then we have alpha thalassemia minor. If only one gene is mutated, clinically there are no findings, patient is just a carrier. If there are two mutated genes, it is a alpha thalassemia trait. Then under beta thalassemia, again we have beta thalassemia major and minor. If only one gene is mutated, it is minor. When there are two genes mutated in beta thalassemia, it is called as beta thalassemia major. It is mild to moderate manifestation. And most of them, when we say thalassemia, the common ones are beta thalassemias, of which the beta thalassemia major is quite common, and it is called as Cooley's anemia. So the mnemonic for thalassemia in pertaining to the histological findings is Thal standing for thalassemia, T for target cells, H for Howell Jolly bodies, A for anisocytosis, and L for low MCV, that is mean corpuscular volume. So histopathologically, when you see the peripheral smear, you can see hypochromic microcytic anemia. Radiographically, the classical finding for thalassemia is hair on end appearance. Apart from thalassemia, you have other conditions where hair on end appearance occurs. The mnemonic for that is THINGS. THINGS stands for thalassemia, hereditary spherocytosis, iron deficiency anemia, neuroblastoma, G6PD deficiency, and sickle cell disease. Of all the findings, the classical one where you can see hair on end appearance or salt and pepper appearance is for thalassemia, hereditary spherocytosis, and sickle cell disease. Other findings for thalassemia include rodent faces, which is typical for thalassemia major. You can see it in CT as well as clinical appearance. So, in the CT you can see CT or other X-rays, you can see in the radiographic feature includes a prominent maxillary and cheekbone with the depression of nasal bridge. Clinically, you can see frontal bossing of the skull, mongoloid slant of eye, there is depression of the nasal bridge, hypertrophy of maxilla, and malar prominence is there. Next one is sickle cell anemia. So, sickle cell anemia is a hereditary hemolytic anemia. There is hemolysis that is happening. The reason for that is the sickling shape of the RBC. So, what happens? Why there is sickling? It is a genetic mutation that happens in sickle cell disease. So, in a normal hemoglobin, in the 6th position, there is glutamic acid, glutamate, whereas in sickle cell anemia, the glutamic acid is replaced by valine in the 6th position, and because of that reason, there is sickling happening in the normal RBC cell, and this is called as sickle cell disease. Next condition is erythroblastosis fetalis. So, erythroblastosis fetalis occurs when the Rh positive mother and Rh negative mother, during the first pregnancy, if the child is a Rh positive child, then what happens is the Rh positive baby's blood cell, it enters a mother's bloodstream. So, because of that reason, the mother will develop antibodies for that, because the mother is a Rh negative mother and the child is Rh positive. So, because of that reason, the negative mother will develop antibodies against the positive child. But that is only after the birth of the child, it will produce the antibody for the first pregnancy. So, what happens is, when there is second pregnancy and also the mother is having Rh positive baby in the second pregnancy as well, what happens is, now there are already formed antibodies in the negative mother against the positive baby. So, because of that reason, these antibodies will attack the Rh positive baby's blood, causing the disease. This is called as erythroblastosis fetalis. So, again I will repeat once again, erythroblastosis fetalis occurs between Rh negative and a positive father, Rh negative mother. When the mother carries a positive baby for the first pregnancy, what happens is, after the pregnancy, the Rh negative mother develops antibodies against Rh positive baby. Because of that reason, in the second pregnancy, the antibodies formed in the negative mother against the positive baby will attack the second pregnancy baby when the second baby is also a Rh positive baby. If the baby is Rh negative baby, no issues at all. But if the baby is Rh positive baby, in the second pregnancy, the baby will end up with complications leading to erythroblastosis fetalis. The severe conditions will lead to even death, but the minor ones or the mild to moderate ones, after the birth of the baby, you can find certain findings. So, the ground section of the teeth will have bilirubin or other blood products. The teeth will have different colors of hue depending upon what type of blood pigment is there. In case of biliverdin or bilirubin, you will have hues relate greenish hue or even brownish hue in case of bilirubin pigment. Then the child will have enamel hypoplasia, typically present on the incisal edges and the cusp tip. This gives a ring-like effect on the teeth, and this is called as RH hump. So, RH hump is nothing but an enamel hypoplasia which appears on the incisal edges and the cuspal tips of the deciduous teeth for the baby, which gives a ring-like effect. The diagnosis is positive direct Coombs test for erythroblastosis fetalis. Next one is iron deficiency anemia. So, iron deficiency anemia occurs because of various reasons like increased blood loss or increased requirements like in case of pregnancy, or inadequate dietary intake, or decreased intestinal absorption. Under iron deficiency anemia, there is an important condition called as Plummer-Vinson syndrome, or other name is Patterson-Brown-Kelly syndrome. Oral manifestation includes dysphagia, iron deficiency anemia, atrophic glossitis, ankylostomatitis and koilonychia. So, these are some of the classical clinical manifestation, of which the triad of Plummer-Vinson syndrome includes esophageal web, iron deficiency anemia and atrophic glossitis. So, this esophageal web will manifest as dysphagia for the patient. So, the triad for Plummer-Vinson syndrome is three things: esophageal varices or dysphagia, iron deficiency anemia and atrophic glossitis. So, for diagnosis, in barium swallow, which is a radiographic examination, presents as you can find the esophageal web in the postcricoid region. And also Plummer-Vinson syndrome is a pre-malignant condition. There are high chances for leading to postcricoid carcinoma. Now, some findings related to red blood indices for different types of anemia. So, as I have mentioned, anemia, you have microcytic anemia, macrocytic anemia and a normocytic anemia. So, normocytic means the cell sizes are normal, just that the count is less. So, which means the MCV means mean corpuscular volume, MCH is mean corpuscular hemoglobin, whereas MCHC is mean corpuscular hemoglobin concentration, and RDW is red cell distribution width. So, forget about all these things, just remember MCV, MCH almost they are interrelated. Whenever you see a normocytic anemia, the MCV will be normal, just that the count will be less. In case of macrocytic anemia, which means the cells are larger in size. So, you will find MCV as well as MCH, everything will be larger in size. The reason for that is the cell is larger, which means the corpuscular volume will be higher. In case of microcytic anemia, the MCV, MCH, MCHC will be lower. The reason for that is the cell's size is smaller. So, how do you differentiate? Another typical finding for iron deficiency anemia is TIBC, that is total iron binding capacity. So, the total iron binding capacity is one of the feature which is required for the final diagnosis of iron deficiency anemia. Next one is polycythemia vera. So, we saw from different types of anemia, which is the reduction in the cell. When there is increased cell level, it is called as polycythemia vera. The other name for that include Osler disease and Vaquez disease. There is increased blood cell level because of overproduction by the bone marrow. So, next is diseases involving WBC. So, diseases involving WBC, before knowing that, you should know the normal range of them. So, under WBC, we have neutrophils, monocytes, eosinophil, lymphocyte and basophil. The normal ranges for them for the RBC as total, it is 4.5 to 6 million per microliter. For WBC, it is 5,000 to 10,000 per microliter, and platelets, it is 1.5 to 3 lakh. Now, these WBCs, from the stem cell, there is myeloid series and lymphoid series, of which the myeloid series only gives rise to majority of the blood cell. So, the myeloid series will give to the normoblast series will gives to red blood cells. Then we have megakaryocytes, which leads to platelets. Then we have myeloblast, which leads to the formation of granulocytes. So, when you say granulocyte, it has 3 WBCs in it. They include neutrophil, basophil and eosinophil, whereas the lymphoid stem cell series gives rise to the lymphoblast, which leads to the production of the lymphocyte, T lymphocyte. Mainly the lymphocyte is produced from the lymphoid cell series, whereas all the even including monocyte is derived from the myeloblast series only. So, agranulocytosis. So, agranulocytosis is when the WBC count is below 2000 cell and almost there is a complete absence of granulocytes, whereas the RBCs and platelet cells are quite normal in agranulocytosis. The oral manifestation for agranulocytosis is necrotizing ulceration of the oral mucosa. It also involves gingiva and palate. Apart from that, there is necrotizing ulceration seen in the tonsil and pharynx associated with lymphadenopathy. Cyclic neutropenia. So, cyclic neutropenia occurs at a very classic regular intervals of 3 to 4 weeks. So, the patient will give a typical feature of once in a month, every month they will have oral ulcers present exactly. If the patient is saying second week of that month, the patient will give you a complaint of exactly after 3 weeks or 4 weeks I am getting recurrent ulcers. It can be a frequency of minimum of 3 weeks to even with a frequency of 4 to 5 months. Once in 4 or 5 months, it will have a recurrent feature. So, the patient will have fever, feeling sick, any soreness or ulcers in the mouth, pharyngitis, periodontal disease, loss of appetite, or they are more susceptible to infection because of reduced neutrophils. Next one is infectious mononucleosis, or the other name for that is glandular fever. So, the patient will present with high fever, chills, generalized lymphadenopathy. The patient will have soreness of the throat, and there are other findings as well. So, just remember infectious mononucleosis, the other name for that is glandular fever, and the associated virus related to infectious mononucleosis is Epstein-Barr virus. The diagnosis for infectious mononucleosis is Paul Bernal test or monospot test. Next one is leukemia. So, leukemia, there is progressive overproduction of WBC which appears in circulation as immature cell. So, leukemia, we have 4 types of leukemia: acute lymphoblastic, acute myelogenous, chronic lymphoblastic and chronic myelogenous. So, now just divide them. Acute means faster onset, chronic means slow onset. So, in acute leukemia, because it is faster onset, usually it contains proliferation of more of immature cell, which means more than 20% of blast cells are present, then we term it as acute leukemia. It can be of myeloid series or it can be of lymphoid series, but just remember more than 20% of the precursor blast cells are there, then it is an acute leukemia. If the immature cells are less than 20%, then we term it as chronic leukemia. So, under the acute leukemia, for myeloid series it is acute myeloid leukemia, lymphoid series it is acute lymphoblastic leukemia. Then under the chronic series, if it is myeloid one, chronic myeloid leukemia, now it comes under the myeloproliferative neoplasms. The lymphoid one, it is chronic lymphocytic leukemia. So, one more feature for the leukemia is the gender and age predilection for these types of leukemia. So, just remember AML and ALL, they are usually found in children. So, ALL is typically found in younger children, whereas in chronic the CLL is found in the adults, especially 55 plus, which means old age group. So, just remember ALL is child, CLL is old age, whereas the AML and CML, they are found in both children as well as adult. In the acute, you can think of children, in chronic you can think of adult. Next one, some of the important points related to leukemia is the presence of Philadelphia chromosome. So, presence of Philadelphia chromosome is classical for CML, and what happens here is there is mutation in the chromosome 22 chromosome. Then presence of Oyer rod is classical for AML. So, Oyer rod is present in the myeloblast, and when you see Oyer rods, you can give diagnosis for AML. The oral manifestation of leukemia is, the classical finding is a spontaneous bleeding. Apart from that, you can also see other findings like gingival enlargement, mucosal ulceration, enamel discoloration, candidiasis, petechiae, osteolytic lesions in the mandible, pigmentations, hemorrhagic bullae, and parotid swelling. So, these are some of the other findings, but the classical finding is gingival enlargement with or without necrosis and spontaneous bleeding. These are the typical finding for leukemia. Next one is diseases involving platelets. So, diseases involving platelets, first one is purpura. So, there is difference between purpura, petechiae and ecchymosis. So, under purpura only we have petechiae and purpura. Petechiae means it is very small pinpoint hematoma less than 3 mm in diameter. So, 1 to 3 mm in diameter is petechiae, whereas purpura is more than 3 mm less than 1 cm in diameter, then it is purpura, whereas ecchymosis are large subcutaneous extravasation of blood, and it is usually larger in size, greater than 1 cm in diameter, then we call it as ecchymosis. So, all of them are extravasation of blood basically. So, under purpura we have non-thrombocytopenic purpura and thrombocytopenic purpura. So, non-thrombocytopenic purpura, what happens under that is it is not because of any defect in the platelet, rather there is alteration in the capillary itself. This results in increased permeability leading to purpura. So, non-thrombocytopenic purpura we have Henoch-Schönlein purpura. Then it can occur because of reasons like sepsis, it can be bacterial or viral, or because of any trauma reasons. Whereas thrombocytopenic purpura occurs because of a bleeding disorder. So, whenever we say thrombocytopenic purpura, it means there is a bleeding disorder for the patient. So, it can be mainly because of an immune thrombocytopenic purpura ITP, or it can be because of conditions like leukemia or coagulopathies like disseminated intravascular coagulation. So, now Henoch-Schönlein purpura is a non-thrombocytopenic purpura. What happens is the patient will have vasculitis. There is deposition of IgA in skin and mucous membrane, most common vasculitis of the childhood, and the classical feature for non-thrombocytopenic purpura is non-thrombocytopenic palpable purpura, which means the patient will have something called as a positive glass sign. Then the patient will have abdominal pain, they will have hematuria and arthritis. These are the classical feature for Henoch-Schönlein purpura. Just remember, in Henoch-Schönlein purpura the patient will have vasculitis. Because of that reason the vessel wall dilates, the patient will end up with purpura. It is not a bleeding disorder as such, rather the bleeding happens because of a vessel wall disorder. So, that is why it is called as non-thrombocytopenic purpura. So, there is no thrombocytopenia, rather the thrombocytopenia occurs because of reason like vasculitis. Generally in thrombocytopenic purpura we will have features like prolonged bleeding time, normal clotting time. So, remember, a thrombocytopenia is a bleeding disorder, whereas conditions like hemophilia is a clotting disorder. So, you have something called as bleeding time and clotting time. In thrombocytopenia we have prolonged bleeding time. Patient will have normal clotting time. The capillary fragility will be increased, positive tourniquet test, and clinically you can see petechiae and profuse gingival bleeding. Now, there is something called as Viscot-Aldrich syndrome. So, Viscot-Aldrich syndrome is a thrombocytopenia which occurs because of an immunodeficiency syndrome. The patient will have both quantitative and qualitative defect in the platelet. So, this is a thrombocytopenia where there is platelet count also will be decreased and the platelet quality will be also altered, which means the platelet sizes are smaller and they are lesser in number. So, Viscot-Aldrich syndrome is a condition where there is both quantitative and qualitative defect in the platelet. So, just remember that word, both quantitative and qualitative defect in the platelet leads to Viscot-Aldrich syndrome. It is again another type of thrombocytopenia. Next one is diseases involving clotting system. So, before that you should know about the clotting factor, which is very important. So, we have 12 clotting factors, but numbered from 1 to 13. Factor 6 is absent. So, the mnemonic for that is freshers party tonight, come let's sing, and call seniors please have fun. So, you can refer the clotting factors and remember them with the mnemonic. It is very important, of which the factor 8, 9, 11 factor, the name is very important to remember. You have to remember the alternate names for factor 9 and 11. That is very important. The reason for that is factor 9 is Christmas factor, or other name is plasma thromboplastin component, whereas Factor 11 is plasma thromboplastin antecedent. So, PTC and PTA. There is always confusion between the PTC and PTA. Whenever there is any question related to hemophilia, they usually like to ask question you all know factor 9 and factor 11. You will not make mistake with hemophilia B and C relating to factor 9 and 11, but you will get confused between PTA and PTC. So, you should remember factor 9 is PTC, factor 11 is PTA. And factor 8 name is antihemophilic factor. So, you should never ever forget the factor's name, at least these 3 factors, factor 8, 9 and 11's name. Now, the coagulation pathway, you have intrinsic pathway, extrinsic pathway and common pathway. So, intrinsic pathway, the factors included in intrinsic pathway includes factor 11, 12 and factor 8 and 9. Whereas for extrinsic pathway, it is just factor 7. In common pathway, you have all the other remaining factors. So, now intrinsic pathway, it refers to multiple cascades of protein interaction activated by trauma inside the blood vessel. Whereas extrinsic pathway refers to cascade of protein interaction activated by damaged external surface. So, external is extrinsic pathway. The factor 7 is involved in extrinsic pathway. Whereas in intrinsic pathway, it is factor 8, 9, 11 and 12. So, this is very important. Another MCQ point. Extrinsic pathway is 7, intrinsic pathway is 8, 9, 11 and 12. Now, coming to the diseases of them, hemophilia A is because of deficiency of factor 8, B is deficiency of factor 9, C is deficiency of factor 11 and parahemophilia is a deficiency of clotting factor 5. Now, here hemophilia B is a deficiency of clotting factor 9. So, we know clotting factor 9 is plasma thromboplastin component, that is PTC. So, hemophilia B is PTC whereas hemophilia C is PTA. So, just remember, it is a simple trick to remember, there is already C in hemophilia C. So, it is PTA whereas for hemophilia B it is PTC. Now, depending upon the percentage of clotting factor present in the patient, you can group the hemophilia into severe, moderately severe and mild. According to that only, you can take up the patient for any dental procedures. So, when there is severe, the patient might have spontaneous bleeding predominantly in the joints and muscles. The patient will have present with hemarthrosis. Any dental procedures is highly contraindicated for such patient. Or if required, you need to transfuse the required deficient factor and do dental procedures under hospitalization. Proper hospitalization is required for such patient. For moderately severe also, there is occasional spontaneous bleeding and there can be severe bleeding with trauma or surgery. So, very mild dental procedures like a superficial scaling could be done for such patient, but any severe procedures like an extraction, a traumatic extraction might lead to an emergency condition for such patient. So, it is advisable to do treatment under hospitalization for such patient. Whereas mild hemophilia is when the clotting factor percentage is greater than 5 to 40. So, here only when there is major trauma or surgery only the patient will end up with severe bleeding. Otherwise, you can do cautious dental procedures for patient having mild hemophilia. So, now very important thing is diagnostic test or blood parameters related to clotting pathway. So, to check what type of clotting factor, what test you will incorporate. So, for intrinsic factor, the test is activated partial thromboplastin time and it is used to evaluate the factors such as factors 12, 11, 9, 8, 10, 5 and 2. Whereas for extrinsic pathway, to test it, we can use prothrombin time. So, prothrombin time is used to check the factors 7, 10, 5, 2 and 1. So, now there is a difference between APTT and PTT. So, APTT is activated partial thromboplastin time whereas PTT is partial thromboplastin time. But both of the APTT and PTT, they are mainly used for intrinsic pathway whereas PT is used for extrinsic pathway. So, to remember them, you can remember the mnemonic PT, which is play tennis, extrinsic. So, extrinsic means outside. So, tennis is an outdoor game whereas table tennis is indoor game. So, PTT play table tennis intrinsic pathway, PT play tennis extrinsic pathway. So, you can easily remember them by this mnemonic. Next is the findings which you see related to PT, APTT, bleeding time and platelet count. So, in normal condition everything is normal for a patient. So, in case of hemophilia, what happens? The APTT will be prolonged, whereas in case of any platelet defect, the bleeding time will be prolonged and the platelet count will be either normal or reduced, whereas the other features pertaining to the clotting will be normal, because in platelet defect is a bleeding disorder, which means the bleeding time will be prolonged in platelet defect. Next one is INR. INR is International Normalized Ratio. So, INR is a ratio which is related to patient's prothrombin time. So, this prothrombin time and APTT, usually PT-INR is used for extrinsic factor, APTT is used for intrinsic factor. Now, apart from that, the PT is increased in conditions like reduced vitamin K or reduced factor 7 and patients undergoing anticoagulation drug therapy like vitamin K antagonist. So, we all know vitamin K dependent clotting factors are 2, 7, 9 and 10, and 7 is a extrinsic pathway. So, just remember that way. The test to detect extrinsic pathway is prothrombin time. Vitamin K dependent clotting factor are 2, 7, 9 and 10. So, 7 comes under the extrinsic pathways, which means the vitamin K deficiency can be easily detected by using a prothrombin test, prothrombin time. So, now anticoagulant drugs, there are different anticoagulant drugs which act at various levels. So, we have heparins and low molecular weight heparin which inhibits factor 7, 9 and 11, whereas we have vitamin K antagonist which targets 2, 7, 9 and 10, that is K dependent clotting factors, whereas we have direct thrombin inhibitors which directly inhibits the factor 2, and we have factor 10 inhibitor which inhibits factor 10. Now, the drugs used to treat the clotting disorders include, we have anti-clotting drugs which we have anticoagulants, thrombolytics and antiplatelet drugs. So, anticoagulants, again under that we have direct thrombin inhibitor, indirect thrombin inhibitor, vitamin K epoxy reductase inhibitor and direct factor 10 inhibitor. Under antiplatelet we have COX inhibitor, glycoprotein 2B3A inhibitor and ADP inhibitor. Under thrombolytic we have plasminogen activator. So, just remember, apart from the aspirin which comes under antiplatelet drug, we also have clopidogrel and abscessimab. So, abscessimab is an MCQ question which we know about aspirin and clopidogrel, which is an antiplatelet, but we often forget about the name abscessimab. We think of other different drugs. Abscessimab, though it sounds like a monoclonal antibody, it is a monoclonal antibody, but it has an antiplatelet effect. So, just remember, abscessimab, aspirin and clopidogrel comes under the antiplatelet drug. To facilitate clotting in case of hemophilia, the drugs used include a replacement of the deficient factors, vitamin K and antiplasmin drugs. The next one, last one is the coagulopathies. So, coagulopathy, the main important one is disseminated intravascular coagulation, also called as consumption coagulopathy. The reason for the name consumption coagulopathy is because of any triggered reason, what happens is all the platelets and clotting factors will be used up. So, what happens initially is because of DIC, because of various reasons when it gets triggered, initially there is too much clotting and due to that reason all the platelets and clotting factors will be used up. So, eventually it leads to bleeding for the patient. The reason for that is since all the platelets and clotting factors are used up, there are no more platelets or clotting factors to stop the bleeding. So, with the slightest injury also the patient will end up with bleeding. And when there is initial coagulation, the patient will end up with organ ischemia. So, DIC can be because of various causes. You can group them majoritively as obstetric causes and non-obstetric reason. So, obstetric reason, there are various reasons that is very common for DIC. Apart from that, you have other reasons also which causes DIC. So, what happens in DIC is there is uncontrolled thrombin generation. So, because of that reason, there is fibrin deposition in the microcirculation leading to ischemic tissue damage, finally leading to multiple organ failure, and also because there is a consumption of platelets and coagulation factors, the patient will end up with diffuse bleeding. So, when there is fibrin deposition, automatically what happens is because there is too much fibrin in the blood cell, fibrinolytic pathway gets activated, and due to that reason the patient will have a lot of fibrin degraded products, FDP. So, in the clinically in the blood parameter, we check for something called as D-dimer count. So, D-dimer count is nothing but fibrin degradation product, which are multiple fibrin degraded products which are present in the blood, that is indicative of some active DIC happening for the patient. So, when you check the blood parameter, when you see an alarming level of D-dimer, it is indicative of some active DIC happening for the patient. So, the condition, the non-obstetric reasons which mainly leads to DIC includes any bacterial infection, viral infection, parasitic infection, or any neoplastic condition, immunological disorders or vascular disorders, any massive tissue injury, reactions to toxins like snake bite, or other reasons like hepatic failure, pancreatitis. So, any infection or sepsis might lead to triggering condition for DIC. So, now to recap the whole things which we saw for today, we saw diseases of RBC. Under that we saw pernicious anemia, the difference between a pernicious anemia and a megaloblastic anemia, what is an intrinsic factor of Castle and what is an extrinsic factor, how calcium is involved in the absorption of vitamin B12, and the findings of megaloblastic anemia, that is the megakaryocyte macrocytic anemia, how it presents, MCV values, and the values for other microcytic anemias. Then we also saw about iron deficiency anemia, Plummer-Vinson syndrome, the triad for Plummer-Vinson syndrome. And then we also saw about aplastic anemia, the primary type, commonest one is Fanconi's anemia, then you have secondary aplastic anemia. Then we finally saw about thalassemia, the classifications of them, alpha thalassemia and beta thalassemia, how it presents, some of the features of thalassemia like the hair on end appearance and rodent facies, and sickle cell anemia, what happens in the sickle cell, why there is sickling happening. There is replacement of glutamate to valine in the 6th position of RBC. So, because of that reason there is sickling happening. And we saw in the diseases of WBC, we read about agranulocytosis, then cyclic neutropenia, some of the oral features of them, then infectious mononucleosis, the virus associated with them is Epstein-Barr virus. Infectious mononucleosis also called as glandular fever. Then we also saw about leukemia, the types of leukemia, and the predilection for age and gender for different types of leukemia, and Philadelphia chromosome and Oyer rods present in what type of classical leukemia. Then we finally saw about diseases of platelets, wherein we saw bleeding disorders, which includes non-thrombocytopenic purpura, the classical one is Henoch-Schönlein purpura. Then we saw thrombocytopenic purpura. The findings of them, we have prolonged bleeding time whereas normal clotting time. Then we saw disorders of clotting mechanism. We saw the intrinsic extrinsic pathway, the test of clotting pathway, then hemophilia A, B, C, and the factors involved in it. And finally, we ended up with coagulopathy, where we saw about disseminated intravascular coagulation and the findings related to them. Thank you all.